Hello, I just wanted to give some more update audio and some slides on areas that I feel may not have been fully discussed in class. So this is just a short one to review juvenile idiopathic arthritis. This used to be known as rheumatoid arthritis, juvenile rheumatoid arthritis. Also used to be called idiopathic arthritis of childhood. Now, if you remember your word parts, idiopathic means they don't know what causes it. The reason it's really not called juvenile rheumatoid arthritis is not every child who has this has a positive Rh factor. They may have a positive ANA, but not a positive Rh. But regardless of what the labs say, they do have an inflammatory attack on the joints that seems to be systemic. So it is an arthritis. It is not an osteoarthritis. You do want to know the difference between osteoarthritis and juvenile idiopathic arthritis. So what could cause this type of arthritis in a child? First, there is an immunogenic susceptibility, meaning that their genetic makeup, for whatever reason, maybe it was the perfect storm between the parents, created a genetic susceptibility to the autoimmune or this self-attack on joints. It's also thought that commonly an environmental trigger can trigger exacerbations or episodes of this arthritis. Commonly when a child will first present with these type of symptoms, when they're taking the history, they will find going back that the child may have had what appeared to be a simple cold or flu bug a few weeks to a month prior. And that is what is thought of as the environmental trigger. Often, they've also found this with juvenile diabetes that causes the autoimmune response against the pancreas. They've found that the children have commonly had a cold a few weeks prior to. Nothing solid to support that, but it is out there and it is a thought. So when does this commonly occur? Well, it can occur through all ages, but the peak onset, when it is most commonly seen for the first time, is between ages 1 to 3 years of age. Because 1 to 2 is oftentimes a nonverbal, this can often go undiagnosed, and because it can be self-limiting, it'll go undiagnosed because the symptoms improve and the child isn't bothered by it again. So when you say juvenile idiopathic arthritis, yes, you think of the joints, but it's actually a group of symptoms, a group of diseases or such. You have a systemic onset with this. It's systemic meaning the entire body, the entire system. So you may see a high fever, a rash. You may see enlargement of the liver and the spleen, hepatosplenomegaly, which means enlarged liver and spleen. Inflammation of the lining around the heart, pericarditis. Pleuritis, which is inflammation of the membrane that lines the lungs. Or lymphadenopathy. So you may not see all of those symptoms, but you will see some of those symptoms. Then there are 3 other categories where you're going to see grouping of symptoms. The first is oligoarthritic, and this involves less than or equal to 4 joints. So it can be both wrists and shoulders, or it can be 5 fingers on a hand. Polyarthritic involves greater than or equal to 5 joints. Often these children are going to be overwhelmingly in pain and very limited in activity. They are going to have inflammation in their back, in their hips, in their knees as well. And then the third and final type is psoriatic. And with this, enthesitis, an undifferentiated type, with this you're going to see not only joint involvement, but you're going to see dermatological involvement. You'll see the red and large, patchy, irritated, inflamed areas on the skin, and commonly those can be over joint areas that are affected. So, of the affected children, they have found 90% are negative for rheumatic factor, and that's what I said at the beginning. That's why it's no longer called rheumatoid arthritis. Not unusual that the symptoms are going to burn out and they go away, they become inactive. If it doesn't become inactive, what you will see is chronic inflammation of the fluid in the joint, the synovium, and you'll see pocketing of fluid, and this fluid is inflamed, it's purulent, it causes destruction of the cartilage, scarring and deformation of the joints, which then causes chronic pain and disability. So there's no definitive diagnostic tests for this. It's based on symptoms and pattern of symptoms. They do look, sometimes the child will have an elevated ESR or sedimentation rate, but not always. Positive ANA or anti-nuclear bodies. They may see during exacerbation when the pain is acute, leukocytosis. But for the most part, they make the diagnosis based on the symptoms. So it's a list of criteria that is put out by the American College of Rheumatology. So there is no cure for it. So you want to treat the symptoms, preserve function, try to protect the joints, and protect their ability to provide self-care and perform activities of daily living. For the most part, patients who are suffering with juvenile idiopathic arthritis are treated outpatient. They may have a suppressed immune system. Commonly, their exacerbations are not so acute that they require inpatient hospitalization, and it is better to protect their health by treating them outpatient. So how do we treat this? The first medication used in treatment is a non-steroidal anti-inflammatory drug, an NSAID. This may be ibuprofen, but you'll see they're going to go to stronger medication. So you will see naproxen sodium, also known as Aleve. You may see the use of Toradol or meloxicam, or much more powerful non-steroidal medications. With that, then you need to provide teaching on protecting the GI system with those medications. They may also do slow-acting anti-rheumatic drugs. You'll definitely anticipate steroids, which helps to reduce the inflammation in the autoimmune response. You will see in advanced cases the use of methotrexate or cytotoxic agents. This is an early form of chemotherapy, actually, but what it does is it kills off those fighter cells that are getting all hyped up and attacking areas of the body that they don't need to be attacking. And then potentially biologic agents, but these are reserved for those few cases where their life is at risk and the other medications have not assisted in reducing the symptoms and the destruction of the joints. So you can also anticipate a patient with this idiopathic arthritis is going to receive physical therapy and occupational therapy. Now, does that mean if their joints are in an all-out painful exacerbation, they should be doing weightlifting and knee exercises or vigorous activity? Of course not. Physical therapy will teach them exercises that they can do when they're not in exacerbation, and then things that they should do when they are having a lot of joint pain to alleviate that pain. Big goal of this treatment is to relieve pain, promote general health, lots of education, encourage the use of heat and ice for joints, whichever helps better. Typically ice is for injury, heat is for non-injury. And then exercise, but only if it doesn't aggravate any current exacerbations of the joints. And then lots of support to the child and the family. They will have to change their daily habits, their lifestyle, and it will be a stressful change for the family. So, a little scenario here. We have a 16-year-old boy who wants to participate in his upcoming baseball season, but he has frequent elbow effusions and chronic pain due to the idiopathic arthritis. It causes him to feel powerless and isolated. He is depressed and wants to quit the sport that he has played since he was 5. How can the nurse assist the teenager with full activity participation and safely protect his bones and joints? So in this case, if he is having an exacerbation and he's already got effusions and chronic pain in his elbow, he doesn't need to be throwing. Certainly wouldn't want him in the outfield making long throws. But obviously the camaraderie and the sport is important to him, so you need to work with the coach. Perhaps he can manage first or third base coaching runners. He can do the scorebook. He can, when he's having good weeks, which this isn't a constant aggravation, when he is having good pain-free weeks, he can do some gentle throwing, maybe get in and play a few innings, but not to overdo it. So lots of education and working with the team on that. Okay, I'm going to stop there and then we'll move on with fracture.